Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answer opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Amy DeZern, an Associate Professor of Oncology and Medicine at the Johns Hopkins University School of Medicine. Dr. DeZern is board certified in internal medicine and hematology oncology and is active in the Division of Hematology Malignancies Leukemia Program at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. She is a member of the American Society of Hematology, the American Society of Clinical Oncology, and the American Society for Transplantation and Cellular Therapy. Dr. DeZern's primary clinical and research interests are focused on bone marrow failure disorders. She has expertise in the diagnosis and treatment of myelodysplastic syndromes and acute leukemias. She sees clinic patients weekly with these diagnoses, as well as patients in need of bone marrow transplants. She is dedicated to improving the care and outcomes of patients with these conditions. To that end, she is an active clinical researcher who specializes in clinical studies of diagnostics and maintains a database of samples and clinical information for outcomes research in marrow failure and leukemia. She is the principal investigator of a number of clinical protocols for patients with MDS. As a clinical investigator, Dr. DeZern's goal is to improve outcomes for patients with bone marrow failure at the bedside and in her research environment. Her work has resulted in multiple publications in the scientific literature and presentations at national meetings. So with that said, it is my pleasure to introduce Dr. DeZern.
Hello, everyone. Thank you so much for joining us with the MDS Foundation and updates from ASH 2020. What I hope to share with you today is all of the promising treatment advances for both MDS and then some for AML that came out in this year's ASH in December of 2020. So as you may realize, ASH is our national and international meeting for hematology, and there's a strong focus on hematologic malignancies. So jumping right in, I have a few disclosures which are listed here. And then I did want to start with some thanks to the authors of each abstract that I'll be sharing with you today, as they actually shared the primary slides with us so that I can really show you the original data just as if you had been at ASH. There's so many things I could have spoken about today, and in frankness, I had 190 slides when I started putting this together, but I assure you I've tailored it down for our 45 minutes together. But just to give you a flavor of how much enthusiasm there is and research and active efforts for our MDS and AML patients, there were multiple satellite symposiums on the Friday before ASH started. There were dedicated education sessions for both MDS and AML, where 3 experts in each field educated trainees and other practitioners about some of the advances. The scientific sessions were fantastic. We're going to focus on clinical and therapeutic work today, but just realize that our bench scientists and translational colleagues had a myeloid workshop, which had some tremendous both mouse models as well as primary patient safety and sample data from their work in the lab, which is exciting. A lot of that bench science is currently focused on a specific mutation or a pathway, which ultimately allows us to develop drugs for our patients. And then certainly bone marrow transplant or BMT had a lot of efforts represented, and I will show you one representative abstract in that regard. So I think this particular group likely needs no introduction to MDS, but just to think about how we structure a meeting like ASH for the science of this disorder. There's always a lot of focus on the heterogeneous nature of the multiple flavors that MDS can take. You see here the epidemiology the number of new cases each year, how old the patients present, and that it's a little male compared to female predominance. Increasingly, there's also studies looking at differences by gender or race or sex, and it's a really burgeoning area for epidemiology as well. There's always a focus on the marrow failure, and we do learn a lot from our inherited marrow failure colleagues as well. Best supportive care is often studied, though not presented as much this year at ASH, and transplant is the potential path to cure. Over the years, our diagnostics have been quite evolving. I suspect many in this group know the International Prognostic Scoring System revised number for them or for their loved ones. The WHO classification is what our hematopathology colleagues often learn about, and they're always at the ASH meeting to both talk and think about how to go forward. And molecular profiling, such as next generation sequencing, is increasingly common. But it's really these evolving therapies that you want to hear about today. As you probably know, there are now 5 FDA-approved drugs specifically for MDS. Azacitidine, decitabine, and lenalidomide have long been approved. And then 2020, despite some of its less positive aspects like COVID, did rein in 2 new drugs for myelodysplastic syndrome. Luspatercept was approved in April of 2020, and Incovy, or oral decitabine cedazuridine, was approved in August. There's a lot of clinical trials, and that's going to be the focus I want to share with you today, so you've heard some of the new and potential exciting drugs that we have in the field. The genetics are evolving rapidly, both from a diagnostic and prognostic perspective. We're really making remarkable headway in our understanding of the genetics, as well as how we prognosticate. And I think you're going to increasingly see that this evolves over the coming years. I'm not going to talk about any abstracts in this regard, but I did just want you to know how much ongoing research and effort is being made for things that are even sponsored by the MDS Foundation on the scientific side, like the International Working Group, which had a meeting trying to correlate some of the genetics with the IPSSR, and we're looking forward to these efforts as we move ahead. The goals are constant from a therapeutic perspective for our MDS patients. They are slightly varied between lower risk and higher risk disease. In lower risk disease, obviously we need a monitoring plan. And for anemic patients, we need a transfusion plan, and hopefully we can decrease those transfusion needs. And I'll show you 2 therapies that fit that metric. We must decrease the impact to quality of life. This is increasingly recognized in the field, and more patient-reported outcomes are coming out at meetings like ASH. And I think it's so valuable to hear the patient perspective on clinical trials as well. We're slightly less worried about transformation to AML for those with lower risk MDS, but we're always trying to maximize the benefit for our patients. For higher risk disease, we are trying to usually decrease the blasts and lower the risk of transformation to AML, and we may be moving toward a definitive therapy, but again, always maximizing benefit for our patients. One challenge I just wanted to mention to the group is that targeting molecular mutations and understanding the complicated disease biology remains an effort at the utmost levels. Today, we're going to focus on the therapeutic implications of new drugs, but in the background, just know that our translational and bench science colleagues are always understanding the normal stem cell biology, then understanding the way in which MDS stem cell biology differs. This could equally represent an AML stem cell. And then understanding the way the clones emerge and change over the course of an individual patient's disease. And we increasingly correlate the gene mutations and the clinical features of a patient. As this disease is clonal and evolves over the course of a patient's lifetime, we have to understand which mutations that or pathways we really want to target, and those which may not require targeted inhibition. So some themes from this year's ASH, and actually the past several years in MDS therapeutic clinical trials, is that quite often we combine therapies, usually a hypomethylating agent that's azacitidine or decitabine, alone compared to that same agent plus the new investigational product. I suspect all of you have heard of venetoclax, which is approved in AML, and we're trying to learn and figure out how best to use that for patients who carry a diagnosis of MDS. There are increasing use and interest in targeted therapies, again, trying to mirror our AML colleagues in the MDS world. There was not a lot of targeted therapy presented this year at ASH. It had been presented last year and in some of the summer meetings, but I think next year you may see much more and hear about it further. There's some novel drugs we're going to speak about today because I really want you to hear the names. And then certainly newer formulations of the older drugs, the hypomethylating agents, are something that continue to interest us greatly because it's more patient friendly. Much of my focus today is going to be on MDS, but also we must think about AML as this is part of the spectrum of myeloid disorders. The therapeutic goals for leukemia patients aren't distinctly different from those for MDS patients in some ways, but in other ways our focus must be altered just a little bit when we think about either newly diagnosed AML patients or those who have relapsed and refractory disease. Younger patients usually, we think, can tolerate more intensive treatment. Sometimes patients more advanced in years require less intensive treatment, but the goals remain the same. Keep the disease from harming the patient and decide how aggressive we can be with our first therapy to bridge to consolidation. Again, often aiming for cure if that's possible, and always maximizing quality and quantity of life. I have just a select group of AML abstracts today, but there were things in the whole spectrum presented this year. Some of these themes include ongoing studying of venetoclax combinations. Venetoclax is a pill, and there's increasing interest in using it, given it's approved for newly diagnosed AML patients that are less fit for intensive therapy. Continuing to look for all oral regimens. You saw this magrolimab novel drug on the MDS slide, and we're going to talk about it in both diseases. Oral azacitidine, we have some data that expands on what's been presented in the past. And there were quite a lot of abstracts related to the sequencing of FLT3 inhibitors in the AML world. I'm not going to delve extensively into these abstracts, but there is a lot of interest in trying to understand that particular mutation, which is seen in about 30% of newly diagnosed AML patients, how to use the increasingly available drugs there. And I think it's a good model for other potential targeted therapies. Currently, there's a lot approved in MDS and AML, and there was a time when I couldn't have said that quite as easily. You sort of look at the timeline here. We've had azacitidine and decitabine and lenalidomide specifically as approved drugs for MDS. Other cytotoxic chemotherapies has long been used standardly in AML, but you can really just see how the last 5 years or so have been a tremendous boon in the myeloid space for treatments for our patients. So let's jump right into the abstracts we have to review. I'm going to begin with those for lower risk disease that are novel approaches. So the first is a drug called imetelstat, and this was studied by Dr. Plotzbecker and his colleagues in an international phase 2 that expressed a desire to decrease the transfusion dependence for patients with lower risk disease who had already progressed through erythropoiesis stimulating agents, something like a darbepoetin or a Procrit or an Epogen alpha. Imetelstat is an interesting drug. It's a first-in-class telomerase inhibitor. And what's really interesting is it has the ability to modify, we think, the natural history of a patient's MDS. Now, you might say, what's a telomerase inhibitor anyway? And telomeres are the end caps of our DNA, which protect it from damage. And because imetelstat inhibits telomerase, which might be breaking down those telomeres and not protecting our DNA, it may have the ability to protect the cells a bit better and allow the recovery of normal red cells, white cells, and platelets. It also may have some potential for selective killing of malignant stem cells, and that is very desirable. So the eMERGE study was actually a phase 2 study design. I've mentioned the eligible patient population of lower risk patients. I will mention these were non-del(5q) patients, and they had already received ESA or had a baseline erythropoietin level of greater than 500. And the goal was to look at transfusion independence. The phase 2 has completely enrolled. And just one of the reasons I wanted you to hear about this drug is the phase 3 is currently enrolling, and this might have a role for some of you. Imetelstat is randomized in a 2-to-1 fashion with a placebo. The results from the phase 2 actually were just published about a month ago by the time you see this in the Journal of Clinical Oncology. David Steensma is the first author there. So here at ASH, they presented some of the results of 38 patients who fit the profile. The follow-up, as you can see, was nearly 2 years, and some patients less, some patients more. And most patients had had about 9 cycles. What's important to realize is these patients were able to become transfusion independent. So 42%, or 16 of the 38, became transfusion independent. The time to onset of that 8-week transfusion independent had a range. Some were very quick, some took longer, but that's still quite clinically meaningful for patients who want to spend less time in a chair receiving a red cell transfusion. About a third of the patients had still been transfusion independent at 1 year. This is something called a swimmer's plot, and I really like to look at these because it's a good pictorial representation of how a patient can receive a treatment. The treatment ongoing here is the black triangles pointing to the right. Everybody started here at time 0. The red diamonds are transfusion episodes. But for example, take this patient here. They got a couple transfusions after they started their drug, and then they have this green period of transfusion independence for more than 8 weeks. And you can see a lot of green periods in this slide. And this shows that this is changing the time that a patient spends getting transfusions. And this is something that gives us a lot of enthusiasm. The longest transfusion-free period was someone who went 2.7 years. So some of the key conclusions for you to take home today about imetelstat in lower risk non-del(5q) MDS are that it really has meaningful and durable transfusion independence. I've reviewed the rates with you. I didn't focus on hematologic improvement erythroid, but 2/3 of the patient had a rise in their hemoglobin, maybe not transfusion independence, but still less time getting red cells. That transfusion independence was across multiple flavors of lower risk MDS, which is important. We don't want it only for one small subset if we can help more. And I mentioned there's that paper in JCO where you can read more about the first phase of it, and there's not any safety concerns with the drug there either. But the phase 3 trial is ongoing and might be something for you to consider. So moving ahead, let's think about an older drug, lenalidomide. This is the interim analysis of a trial conducted by Dr. Diaz-Campello and her colleagues in Europe. And this is a trial trying to answer the question as to whether or not giving lenalidomide early in a patient's disease course for their del(5q) myelodysplastic syndrome at lower doses than someone who is transfusion dependent and more advanced in their del(5q) MDS course can help prolong the time until an MDS patient like this becomes transfusion dependent and ultimately improve their outcome. So while this is a busy slide, just recognize these are non-transfusion dependent but anemic del(5q) patients who either received lower dose lenalidomide at 5 milligrams daily or a placebo, and then followed these patients to see if we were able to change the natural history. To give you a flavor, I chose a slide about the patient's disposition because you might want to know how the patients felt about this and how their physicians felt about it. And so look down here at the discontinued percentage. So of the 40 patients who received lenalidomide, about half of them stopped over the course of the trial. Very few of them were for noncompliance. About a quarter, the physician thought they should stop. But progressive disease was only about 38% compared to 71% of the placebo cohort who needed to stop because their disease required active treatment instead of continuing to get the placebo. So that may really be a signal that the lenalidomide is doing something for these patients. This is a pictorial representation in a way of the same. The time to transfusion dependency is an important metric for del(5q) patients. Remember, the lenalidomide or the placebo were being started for these patients very early in their disease course at a lower dose. And you can see that the lenalidomide decreased in almost 2/3 of the patients the risk of transfusion independence. And that's why this blue line on the top shows a longer time until the patients needed transfusions compared to those who were only getting the placebo. And so a difference of 6.3 years compared to 2.8 years. That's a lot of time with less healthcare interactions. Some people might worry that getting chemo too soon could cause AML or things like that, and that is not what this cohort showed. So some key conclusions from this abstract is that early lenalidomide at low doses prolongs the time to and decreases the risk of transfusion dependence. About 3/4 of the patients had some augmentation in their hemoglobin, which is good. And this I mentioned was an interim analysis. They will show us probably at next year's ASH or maybe a little longer if there's any impact on the natural history and longer term outcome for these patients. So something to consider if you know you have del(5q, maybe not getting transfusions, but how soon should your chemo be started or not? So let's move ahead to higher risk MDS. And this particular abstract is on transplant. And I think it's particularly high yield and possibly practice changing, especially in the community. And then I'm going to show you how it has some practical insurance implications as well. So this is a little complicated. I want to make sure I do it justice. This is a blood and marrow transplant clinical trials network study. So the BMT-CTN is a large cooperative group that conducts a lot of the multi-center transplant trials throughout the United States. So this trial was conducted at many centers, and it's biologic assignment trial comparing a certain type of bone marrow transplant to azacitidine or best supportive care in patients who are between the ages of 50 and 75 who had higher risk myelodysplastic syndrome. The title is a lot wordy, but for the study design, it's open label, and the patients were assigned to their cohort based on their HLA typing for transplant, and that's why it was called a biological assignment. And if a donor was available to the patient, that subject was expected, if medically reasonable, to undergo transplant within 6 months. I mentioned the subject's age and that these were patients that had MDS that was deemed higher risk by the International Prognostic Scoring System. And of course, everyone needed to be considered as a transplant candidate. And then what their therapy was ultimately per institutional standards. So this trial accrued very robustly, which you might think is surprising. Some people were surprised, but this trial did great with 384 patients. And of those patients, 260 had a donor identified by that HLA typing that I mentioned. 124 unfortunately did not. And you can see the rates of some of the way people ended up here. But let's take it into more detail. 3-year overall survival is an important metric for anybody, but specifically in the transplant community, there's a lot of outcomes at 3 years. And this was the primary endpoint of this study. So this is all the patients, the black line representing those who had a donor, and the yellow line those who did not. And the absolute improvement in survival if you had a donor was over 20%. So you can see that separation in the curves is fairly significant. This is probably the slide that you really want to know, though. This was the as treated, and this means that the patients actually went to transplant. So there's an even further split between these, having a donor with the black line and not having a donor, unfortunately, is the yellow line. And again, an improvement in survival if the patients were able to get to transplant, and a longer time till when those patients got leukemia if they went to transplant. You might say, well, that's wonderful. Living longer and not having leukemia is very meaningful, but did the patients feel significantly worse? And actually, the answer is no. So obviously, I've truncated the entire presentation just for our time limitations, but this is a slide about the quality of life assessments between the patients who had a donor in purple and those who did not in yellow. And you can see, by and large, the bars are about the same. This is a fatigue score, which was similar. This is a mental acuity score, which is similar. The physical components were similar. And then this is just how they viewed the utility. And I think it shows that going to transplant might not be as detrimental physically or mentally as some people might have thought a priori. So some key conclusions for this. It's a specific population of transplant, high-risk MDS in this age group. But the data does illustrate that having a suitable donor leads to improved outcomes. Later in the question and answer session, perhaps we can talk about what a suitable donor means. The overall survival was improved by that greater than 20% number I mentioned, and also the leukemia-free survival. Something I didn't show you for the interest of time, but I want to mention, is that subjects greater than age 65, so you see the age range, but those in the Medicare age range had very similar results to those who were younger than age 65. And this is the paperwork insurance practical implication of this trial that I alluded to. There's no decrease in quality of life compared to the no donor controls. That's very important. And the as treated analysis really suggested a stronger advantage for transplant over not going to transplant. That was the greater than 30% number. So I think the reason I feel this may be practice changing is we've seen data in many years past that referral to transplant centers is often delayed until it might be too late, or the thought by the treating provider is that the patient's not a transplant candidate, or they don't have a suitable donor, or whatever reason, it just isn't even considered. But early referral to a transplant center and ensuring that those patients over age 65 can have coverage by Medicare for a transplant, which currently the wording is complicated in MDS. And so I think you're going to see some things change based on this trial. All right, let's move ahead to novel approaches in higher risk disease. We focused on imetelstat and lenalidomide for lower risk. We had a transplant abstract, and now these are novel drugs in higher risk disease. I've chosen these slides because these are drugs I feel certain you will be hearing about again. The first is pevonedistat. This was presented by Dr. Sakaris and colleagues. This was an international study of pevonedistat plus azacitidine compared to azacitidine alone. So very much that combination style of trial that is so common in MDS that I alluded to in our theme slide. So pevonedistat is quite an interesting drug as well. It's a first-in-class inhibitor of the NED8 activating enzyme. And these are complicated pathways, but essentially NED8 activating enzyme, blocks some pathways that have to do with the proteins in our cells. And if you treat with this drug, pevonedistat, it disrupts the cell cycle progression and cell survival, which leads to cell death, specifically in the MDS or leukemia cells. And early mouse models had shown that combining it with azacitidine might even be more effective. And this was done in models of AML. So it made sense based on this data to study it in higher risk MDS. This ASH abstract was intended to specifically review the results of the 67 higher risk MDS patients who were analyzed in the intention to treat portion of this trial. So the patients were randomized 1-to-1. You can see that pevonedistat is given through the veins on days 1, 3, and 5. And azacitidine was given in a very standard schedule of days 1 through 5, Monday through Friday, skipping the weekend, and then Monday, Tuesday. So event-free survival, and an event for us would be transformation to leukemia or death, and overall survival favored the combination arm of azacitidine plus the new agent pevonedistat, specifically in the higher risk MDS patients. And again, looking at our Kaplan-Meier curves, you see a split between the red line, which are those who got both drugs, compared to the more gray line who got azacitidine alone. And the event-free survival was a 6-month difference for the median between the combination and the single agent. For overall survival, pevonedistat with azacitidine had a median survival of almost 2 years, whereas azacitidine was a bit shorter at 19. And again, the split of the curves. The red cell and platelet transfusion independence was increased in the combination compared to the azacitidine alone. So this is the red bar here. And how long that transfusion independence lasted was also longer in the combination arm. We always worry in our MDS patients that are higher risk about transformation to AML, and it was delayed. So the time to that happening was longer in patients who got pevonedistat plus azacitidine. What I don't go through in detail here is some of the safety data, because you might think is more better, but I can assure you pevonedistat has quite a favorable safety profile with azacitidine compared to some combinations that we've studied in the past where more was not better. So some key conclusions for our pevonedistat trial is that there were encouraging longer event-free survival and overall survival. The CR rate, I didn't show you some of these curves, but was higher with combination. So complete remission being decrease of those blasts to where you can't see them, and near normalization of the blood counts. And the duration of response was longer. Now you might think, does this conflict with our transplant abstract? But the answer is no. This is just a longer way to keep patients in remission, either because that's what we've decided to do for the whole treatment plan or allows time to get to that transplant center. This is that safety comment I wanted to make. Adverse events are our doctor's way of coding in the trial if things that made a patient less safe or less healthy happened and were attributed with the drug, and the answer was no. And again, I chose this because there's a phase 3 trial that's fully enrolled, and you'll be hearing about more to clarify the findings in this drug and see where it may or may not fit in our arsenal, depending on whether or not it gets approved. Okay, so the next new agent is called sabatolimab, or MBG453. Again, the same style of study presented by Dr. Bruner, who's currently at MGH in Boston, that you give the new agent in combination with a hypomethylating agent. Now, this is a mechanism of action that's been, perhaps you've seen even in the lay press, it's been spoken about a lot. The concept of targeting TIM3. So binding TIM3 on immune cells really might be able to control leukemias. And so this is something that we want to think about. And even to target those leukemia stem cells through binding of the TIM3, again, may allow us to selectively choose the bad cells and get rid of them. This is a pictorial representation of that. This is a macrophage, which is part of our immune system, eating a leukemia stem cell or a blast. And sabatolimab, the new drug we're talking about, can help facilitate this interaction to get rid of the bad cells. That's a fair simplification, but I think you'll see that perhaps there's some suggestion that it will work. So this trial was very early phase. It's a phase 1B, but specifically looking at MDS, AML, and CMML, which we know is an MDS-MPN overlap syndrome. What's nice about this study is they looked at both azacitidine and D-cytidine, which it's important to look at both of our HMAs. And then I have another swimmer's plot here showing that complete response is in the dark blue and ongoing therapy as these larger arrows. And you can see that the median time to response is fairly efficient in our world, about 2 months. And the percentage of patients still responding after 6 months was over 80%. This is longer than many drugs in our field. And that the progression-free survival, so not moving forward to worse disease, was over 50%. And some people worry with drugs that somehow affect the immune system that patients may not do well with transplant because that's another way of affecting the immune system. But 8 patients in this early study were able to move to transplant. So specifically for very high-risk MDS, again, these are encouraging responses. The blue is complete response, but also ongoing ability to receive therapy and other forms of less blasts or hematologic improvement are also seen. And you can see these red marks represent how early that initial response is seen for patients. The same is true of AML, very similar, that patients can be on it for a long time and still respond after 6 months. So sabatolimab in high-risk MDS and AML is safely combined with azacitidine and D-cytidine. And again, treatment-related adverse events were not higher than those just getting azacitidine or D-cytidine alone. I've shown the overall response rates here in this conclusion slide. 64% for higher-risk MDS, 41% for AML, and over 50% for CMML. So again, this is encouraging. And I list here several studies, but one to focus on, that this is another drug that's going into a phase 3 study in higher-risk MDS. So let's move ahead to venetoclax. I mentioned that we would talk about this because it's such an exciting drug in the AML field, but I want to talk about it in the MDS arena. So this is an early phase study using azacitidine in combination with venetoclax for patients with higher risk MDS. Venetoclax is a BCL2 inhibitor. BCL2 is a cell cycle regulator, and to be able to cause breaks in the cell cycle that leads to apoptosis, which is the medical word for cell death, is very effective with venetoclax, and it makes those cells go away. A concern in the community, especially by MDS physicians, has been that perhaps the blasts in AML are cycling more quickly and are not going to be killed in the same way in MDS, and that possibly venetoclax would be too toxic in MDS or it needed to be dosed differently. So this study tried to get at some of that issue. So it's a little complicated. The azacitidine is not complicated. It's 7 days. But then patients were randomized to get different dosing amounts of the venetoclax compared to our AML colleagues. So leukemia patients get venetoclax for 28 days. And here, ultimately, by the time the drug completed, they were only getting it for 2 weeks. So really trying to see if we can get a demonstrable clinical benefit without any overt toxicity to our MDS patients. Similar trials were presented at last year's ASH, but this was also an oral at this year's ASH. The adverse events I list here for you. A lot of patients with MDS did require cycle delay. This is much more than AML, which speaks to why we need to be understanding if less can be effective still. The response rates were good. The overall response rate was listed as 79%. I will grant you only about 40% complete response, and this marrow CR means the blasts went away. And it doesn't necessarily mean the blood counts got better. But then if you look over here at the transfusion independent rates, in fact, they did for both red cells and platelets. This is the overall survival by response of the patients who got this combination. So for CR, the overall survival was almost 28 months. When you decreased your blast, which is that marrow CR, and improved your blood counts, that's the marrow CR plus hematologic improvement, that survival was not reached. That's this right here, which is great. So to summarize, azacitidine plus venetoclax in higher risk MDS, it's efficacious and it is durable. And the safety profile specifically in this patient population is good. That was quite important to us. The recommended dose from this study is 400 milligrams for 14 days or just 2 weeks. And I think you're going to see more coming about this going forward. I'll just jump down in the interest of time to highlighting yet another phase 3 study coming for higher risk patients. It's actually here. It's recruiting and started just a few months ago. And I think this will really answer some of the questions we have about venetoclax in MDS as opposed to AML. Okay, so let's talk about some novel drugs and concepts in both disorders. This is not that novel, but I really chose this abstract to highlight something about oral azacitidine. So oral azacitidine is actually approved as a maintenance therapy in AML patients who already got a remission after induction. And the authors had presented the original trial as a late-breaking abstract a year back, but now that it's approved, they're continuing to study the Quasar trial, which was a phase 3, to have more results. I do want to highlight to the group that oral azacitidine is distinctly different from IV or subcutaneous azacitidine. And sometimes I have people ask me, why can't I just switch to oral AZA now that it's approved? And the reason is because it has a very distinct pharmacokinetic and pharmacodynamic profile. It's currently approved in the US specifically for treatment of adult patients with AML in that first CR, as I mentioned. But a question that this study was trying to ask is, after the patients are in first remission, if their disease status changes, and here that means, are they still in CR? Do they now have more blasts in this range, 5 to 15%, or a lot more blasts? What can happen if you keep using the maintenance therapy as opposed to switching your treatment paradigm altogether? And so the answer to this is, if you use this oral azacitidine specifically in this manner, so different than the other ways we've been talking about it, it can still improve survival. And so this shows that for overall survival, it is longer, nearly 25 months compared to about 15 months for getting the oral azacitidine maintenance, as well as relapse-free survival. But when that escalated dosing happens, when the patients keep getting oral azacitidine and have these marrow assessments to see if blasts have come back, which of course we hope not, what we should do. And in the escalated dosing cohort, the survival was still extended, even if blasts started coming back when the patients keep getting the oral azacitidine. So this gives one option, depending on an individual patient's scenario, to continue an oral therapy as maintenance, even if the disease is eking back in. So the key conclusions are that oral azacitidine is different. I really can't highlight that enough. And that the early relapse, there's still benefits and maybe still some time to make other decisions if you keep taking oral azacitidine, as long as the blasts are less than 15%. So let's move to this particular compound, SY1425. It's a selective RAR alpha agonist in combination with azacitidine for newly diagnosed unfit AML. Now, this drug applies to a very specific subset of AML patients who actually have this RAR alpha positive style of leukemia, and that's a blood test that your physician would identify it with. We need new therapies in this population, and so this study was done for treatment-naive patients with newly diagnosed AML. And you have to have the biomarker. So this is one of the first biomarker-driven studies. And those who were positive received the regimen, and those who were negative, and then things were compared. So if you look at the patients who are positive and stratify by response, the patients that respond, which does stand to reason, do better and live longer. This is not all patients who are going to be positive, and this is an early study specifically in AML, but even those the 11 patients who didn't get a complete response, had a difference in survival compared to those who did get a complete response. We're going to hear more about this drug, which is why I briefly mentioned this abstract, because there's a phase 3 coming specifically for those who are RAR alpha positive with higher risk MDS. So last but certainly not least, I've chosen a very specific drug to end our time together with of the abstracts. Some of you may have already heard about it. It's an anti-CD47 antibody called magrolimab. And these are results that were presented specifically in AML of a phase 1b study. Magrolimab is a macrophage immune checkpoint inhibitor which targets CD47. It's called a don't eat me signal. And CD47, that signal to not be eaten, is overexpressed in quite a few cancers, but including leukemia and MDS. And this particular drug is a monoclonal antibody that eliminates tumor cells through macrophage activation. Now, hopefully this works. Yes. So this is our control. I hope you can see it, that the red cells are not eating the green cells. But in the context of the magrolimab, the anti-CD47, can you see that now the red and the green overlap? And that is the phagocytosis, which means the cancer cells are being eaten. So moving ahead, magrolimab was combined with azacitidine in both AML and MDS patients. The patients were untreated and eligible for therapy. The dose is given weekly, and the azacitidine is given standardly. In the expansion phase, which came after this initial safety evaluation, it was either given weekly or every 2 weeks. And the goal is to understand the safety. You'll remember this was still a phase 1b. And we're going to see the AML results, which were presented at ASH. First and foremost, this drug is well treated. These are the AML patients. And these were adverse events that were seen. You can see the list, some joint pains, lab changes, other symptoms that were seen on the trial, but those that were truly related to the drug, which are on the left side of the line, are fairly small. The maximum tolerated dose was reached, and the profile of the combination safety-wise is really pretty similar to what we see with azacitidine alone. The response rates are what is really exciting. So the overall response rate is about 63%, and the blast reduction, which are those below the line here, is quite significant in the patients. The overall response rate I mentioned, and the CR rate was 42%, which this is high. And one highlight that the authors of this abstract did do at ASH was in the TP53 mutant patients. These are patients who have very high risk disease, as TP53 disease is also usually associated with quite an adverse prognosis, and these patients still respond. And those responses are deep and durable. The patients get red cell transfusion independence, their karyotypes return to normal, and they might not even have minimal residual disease. And these response rates were similar in all patients. I keep showing you these swimmer plots because I think they're good representations. The patients can be on it for a long time and continue to do well, the green or the CRs. I've mentioned the difference between TP53 outcomes generally. They're thought to be unfavorable, but the wild type and the mutant patients are somewhat similar. And I think you'll be hearing more about this drug in all contexts, but especially the TP53 context. So in conclusion, magrolimab is an antibody which targets that CD47. It's well tolerated. And even though it's a monoclonal antibody, there are no significant immune events. TP53 status doesn't seem to matter that much, which is not as true of other drugs. And we're really looking forward to learning more about it. I show you here the phase 3s, which I think you can see one of my themes today was to share with you how many drugs there are available in our world. So I hope in this whirlwind of new data that I've shown you the hope and progress. There's a lot of future questions. There are many, many more abstracts than I could have presented from ASH because it's such an exciting time in the myeloid field. There's new drugs, which I focused on today, but there's efforts at changing the natural history, which is obviously imperative. Personalized therapy is always important. We're still learning about the mutations and what they mean compared to the clinical phenotype. And we want to rationally design our new drugs or therapies and effectively run the trials to learn more and help more patients. Transplant continues to be an active question. So I showed you this slide before, but there's definitely going to be progress and more drugs going forward. I've given you a list today, but there's many more. And I hope this shows you all the promise and future efforts that are ongoing and exciting for you as our patients. So this is just my pictorial representation of ASH, and I hope I've shared some of the science with you today. We know the diagnoses that our patients have. We're increasingly trying to characterize their disease and give a therapy, see if it helps, and then give another therapy or go into long-term follow-up if that's what's needed. Our clinicians make bedside observations. Our bench scientists learn from mice and bring it back to the clinic. And then we're so grateful for our patients who actively participate in clinical trials so that we can bring more drugs to more patients. So we always do this for the patients, both as clinicians and scientists and back and forth. And I really appreciate your time today. And I'm happy to take any and all questions that you have related to this or other ASH things that I wasn't able to get to today. So thank you again, and